Okay. Thank you, everyone, so much for coming. We're so glad to have this opportunity to talk about genetics. And this is the first of a two-part series for us. So this is our first Lunch and Learn conversation that will focus on ovarian cancer family history and genetics. My name is Megan Neubauer, and I'm the Executive Director of the Michigan Ovarian Cancer Alliance. I know that I know many of you. But before I introduce our speaker, just as we were saying, go ahead and put any questions in the chat. We'll have that time at the end. And if you have any trouble with technology throughout, or if anything's not working right, just go ahead and send me a message. You can send it to the whole group, or you can send it to me directly, and I can take a look at that throughout. So with that, we're so glad to have Kara Milliron with us today. Kara is a licensed certified genetic counselor and has worked exclusively in the breast and ovarian cancer risk evaluation program at the Rogel Cancer Center at the University of Michigan since 1998. Kara has a BS in biology from Grand Valley State University and a master's of science in genetic counseling from the University of Pittsburgh. So Kara, I am going to hand it over to you so that
Thank
we
you.
have plenty of time to focus on this important conversation, because I know there are lots of questions and it's a topic that has a lot of information to go over. So thank you so much for being with us today, and I'm looking forward to it.
Well, thank you so much for inviting me, and thank you so much to the participants for giving up an hour of their very busy day to log into this webinar. So as Megan said, my name is Kara. I'm one of the GENT counselors that works in the breast and ovarian cancer risk evaluation program at the Rogel Cancer Center at Michigan Medicine. And what I'd like to talk about today is genetic testing for inherited susceptibility to ovarian cancer. And I have no disclosures to disclose. And what we're going to talk about today are genetics in ovarian cancer, the genetic counseling and genetic testing process, and how genetic testing may impact a patient and their family. So we know that cancer is very common. About 1 in 3 women and 1 in 2 men will be diagnosed with cancer in their lifetime. And cancer is a multifactorial process. It is not just one event. It is many events that coincide to create that cancer diagnosis. We know that about 21,000 women will be diagnosed with ovarian cancer each year. And to get a better understanding of why those women are diagnosed with their ovarian cancer, we really need to start understanding the roots of a cancer diagnosis. And cancer arises from gene mutations or changes in genes. We each have about 20 to 30,000 genes, and they're arranged in pairs with one copy coming from each parent. And their job is to create the instructions for our growth and our development. When there's a mutation or a change in a gene, it causes it to not work properly, and that's where we can see an increased risk for developing cancer. There are 2 ways that gene mutations occur. One is that they occur in the body over time. So it's like acquiring a scar. It is not something that's passed on in families. And that's what we call a somatic mutation. Soma meaning body, that it happens in the body over time. But there are also mutations that are passed on from generation to generation that can contribute to a cancer diagnosis. These are mutations that are found in the egg or the sperm, and so they're present from the very first cell that creates that individual. Most of the genes that are associated with cancer development are tumor suppressor genes. So their role in the body is to make sure that cells grow at a very specific amount of time at a very specific rate. When we look at how cancer develops, as I said, there are 2 ways that mutations happen. And this is just another picture to sort of explain that concept of how cancer can start to grow and develop. So on the left, or my left, I think it's your left as well, what we see is the sporadic or happen by chance cancer development. And what we see here is that in one cell, we have a tumor suppressor from mom and a tumor suppressor gene from dad. And both of those copies of that tumor suppressor gene are normal. So that cell is growing the way that it's supposed to. What happens in this individual is in one cell, as that individual is going through their lifetime, they'll acquire a mutation or a change in one of the tumor suppressor genes that turns it off. This happens in one cell, and this other tumor suppressor gene or the other set of breaks is healthy, so the cell continues to grow the way that it's supposed to. Now, many people will go their whole entire life without any consequences from this step. And we have no idea that it ever even happened. But in that same cell, if an individual acquires a second mutation that turns off the other tumor suppressor gene, now we have one cell that has nothing controlling its growth and development, and that's when a cancer can start to grow. This takes time, and so that's why most cancer cases are unfortunate random chance and happen later in life, because it takes time to acquire those mutations. Individuals with an inherited susceptibility to cancer, it's a different situation. These individuals are born with a mutation, and this mutation came from either their mother or their father, and it was present from birth. So all of the cells of the body have one tumor suppressor gene that's turned off. So all it takes is just in one cell, as that individual is going through their lifetime, they acquire a second mutation in the other tumor suppressor gene. Now they have a cell that has nothing controlling its growth, and that's when cancer can start to grow and develop. And so you can see individuals who have an inherited susceptibility, they're one step closer to developing cancer than those in the general population. What most cancer susceptibility genes? Oh, goodness, I don't know what's going on. Sorry about that. So most cancer susceptibility genes are what we call autosomal dominant with incomplete penetrance. So what that means is that they can be inherited from mother or from father. And when they are inherited, just because someone has the mutation, it doesn't necessarily mean that they are going to develop cancer. It's an increased risk. So it is possible for someone to be born with a gene mutation that causes an increased risk for developing cancer, but they never develop cancer at all, but they pass that gene mutation on to their children. And then their children may develop a cancer diagnosis. So it may appear that it's skipping generations, but it doesn't. It doesn't skip generations. It's important to remember that people inherit the gene mutation, not the cancer diagnosis. Most genes associated with cancer predisposition are what we call tumor suppressor genes. And so those are genes like BRCA1, BRCA2, BRIP1, RAD51C, RAD51D, PALB2. And the other big category is our DNA damage response genes, like MLH1, MSH2, the Lynch syndrome genes. They fall into that category. Genetic counseling is a big part of the genetic testing process, and genetic counseling is non-directive. Genetic counseling is a communication process which deals with the human problems associated with the occurrence or the risk of occurrence of a genetic disorder in a family. Again, genetic counseling is non-directive. The genetic counseling process helps the individual comprehend the medical facts, appreciate the way that hereditary contributes to their health. What is the risk to relatives? Understand the alternatives for managing risk, choose a personalized course of action, and make the best possible adjustment to the situation in the family over time. When we look at the human genome and cancer, cancer was really the big winner in the Human Genome Project out of all of the chronic diseases. We learned that tumorigenesis is a multi-step process due to the Human Genome Project. And it's thought that in general, about 5 to 10% of cancer cases are due to inherited susceptibility. However, when we look at ovarian cancer, up to 20% of ovarian cancer cases can be due to inherited susceptibility. So it is a higher chance if someone is diagnosed with ovarian cancer that is due to inherited susceptibility compared to other cancer diagnoses. And the Human Genome Project helped us understand predictive tests to identify genetic risk, which we call, genetic testing, some diagnostic tests to help detect cancer in early stages, and therapies that target gene abnormalities in cancer cells, like Gleevec, PARP inhibitors, and that sort of thing. When to suspect a hereditary cancer syndrome. Cancer in 2 or more close relatives on the same side of the family, an early age at diagnosis, multiple primary cancers, bilateral or multiple rare cancers, a constellation of tumors consistent with specific syndrome like breast and ovarian cancer, or uterine and colon cancer, ovarian and uterine cancer, ovarian and colon cancer, and evidence of autosomal dominant transmission. What that means is that each parent has a 50-50 chance of passing the gene change on, equally to both male and female children. So you'll see approximately half of the individuals in the family with a cancer diagnosis and approximately half without. Some of the decisions that are influenced by germline genetic testing results. Well, primarily the management of the primary cancer diagnosis or progressive disease. So sometimes that could be surgical decisions, a drug choice, for example, PARP inhibitor, immunotherapy, and others. Follow-up surveillance, should this individual be followed differently based on their genetic test results. And for cancer survivors, management of increased risk for new cancer diagnoses, and surveillance, risk-reducing surgery, discussion of chemo prevention, et cetera. For individuals who don't have a cancer diagnosis, the genetic testing can help us identify individuals who are at higher risk for early detection, enhanced screening, risk-reducing surgery if they are interested, chemo prevention with medications that reduce the risk of developing breast cancer, or birth control pills to help reduce the risk of ovarian cancer. And a lot of the genes that we offer genetic testing for do have reproductive implications. And so sometimes individuals, if they do test positive, think about pre-implantation genetic diagnosis to aid in not passing that particular gene change on to future generations. Genetic testing is an analysis performed to identify mutations present in the whole body from birth. There are several different methods of testing that are available, but typically we use next-gen sequencing, which is the newest form of genetic technology. We try to begin the testing process with someone who has a cancer diagnosis, although sometimes that is not possible. And we only perform genetic testing on children when it will affect their health care or their management. So typically the genetic testing that we offer in our clinic, if there is a gene mutation in the family, we typically don't test anyone under the age of 18 because it will not impact their health care. The cost and insurance coverage varies, but it's much, much improved compared to when I first started back in 1998. Nowadays, it's very rare that an insurance company doesn't cover the cost of the testing. The cost is usually reduced once a mutation is identified in the family. And even so, some labs will even test family members free of charge for a limited amount of time if a mutation is identified in a family member. Usually, they'll cover free testing within 90 to 150 days for that family member. Currently, if someone wanted to pay out of pocket for genetic testing, the out-of-pocket cost would be $250. Some of the benefits, again, of genetic testing can be to personalize management, help make decisions about future medical plan. It may give patients and individuals a greater sense of control and provide relief from uncertainty, and also can help with the grieving process by giving an explanation for the family history of cancer. And genetic testing may be able to identify family members at increased and at normal risk, because if there is a mutation in the family and someone tests negative for that gene mutation, their risk of developing cancer goes back to that of the general population. So that is an important use of healthcare resources as well. Some of the limitations of genetic testing is that it may not detect all mutations, and not all cancer predisposing genes have been identified. Screening and prevention measures are not 100% effective. The timing and location of cancer cannot be predicted, and we all have a background risk for developing cancer. So there are three types of genetic test results. The first is no mutation detected or no changes were identified. In that situation, there was nothing identified in that individual's germline or the genes that they were born with that could be passed on to children. And in that situation, if at-risk relatives are interested, we default to risk assessment to estimate their risk for developing cancer. Pathogenic variant, that result means that a change was identified that increases cancer risk. And all biological relatives are at risk, first, second, third, and even beyond third degree. We strongly encourage sharing the information with family members, and we typically can help with that with a family letter. There's a third type of result that can happen as well, and that's called a variant of unknown or uncertain significance. It doesn't mean that the test is wrong or that the test needs to be repeated, but what it means is that when they're comparing your DNA to what we expect to see, there's a change, and it's not clear if that gene change is associated with an increased risk for developing cancer, or if it's something like having brown eyes or blue eyes, which of course is normal variation from person to person and nothing to be concerned about with regards to health risk. We don't use variants of unknown or uncertain significance to make medical management recommendations, nor do we recommend that other family members be tested for that variant of unknown or uncertain significance, because we just don't know what it means with regards to health risk. The laboratories that perform the testing continue to follow variants of unknown or uncertain significance. And so it is possible that as time goes by, more information becomes available, the lab will be able to give us clarity on what that specific gene change means. We call that in genetics a reclassification. And the majority of the time, the lab is able to say this is something that is not associated with an increased risk for developing cancer. But a few are upgraded. And so we just want to make sure that we stay in contact with everyone, because if we get new information that impacts health risk, we want to make sure that we're able to contact that individual. A lot of times people will say, well, you could do the genetic testing, but really, what are you going to do with that information? And that's very short-sighted. There's a lot actually that we can do for individuals who are at increased risk. For individuals who are at higher risk for ovarian cancer, while it's true that we don't have good screening that has been shown to reduce morbidity and mortality, we do know that risk-reducing bilateral salpingo-oophorectomy or risk-reducing BSO, removal of both ovaries and both fallopian tubes, reduces the risk of ovarian cancer by 90 to 95%. There's also evidence that birth control pill use or oral contraceptive pills will help reduce the risk of developing ovarian cancer. There's also a couple of reports in the scientific literature that tubal ligation may help reduce the risk of developing ovarian cancer. So there's a lot that we can do. We also have increased screening for breast cancer, colon cancer screening with colonoscopies, endoscopic ultrasound or pancreatic MRI for screening for pancreas cancer. And some people do pursue prophylactic risk-reducing surgery, and that is always an option. But again, it's an option, and no one is pressured into doing something that they do not want to do. The importance of genetic counselors is that we are trained specifically in this information. And so we can help with understanding the genetic test results. We can help share that information with the family, and we can be a conduit to the rest of the health system. So we're here to help. And until the majority of other healthcare providers catch up with genetic testing information, we really are the best resources for understanding this information. There are psychological concerns for anyone who undergoes genetic testing, and the right to not know is something that does need to be respected. And if someone doesn't want to know, that's absolutely their right. And we don't coerce or, pressure anyone into pursuing genetic testing. It is a complete right of that patient to pursue what they feel is best for them. We recommend that everybody in the family who's biologically related to that individual who's pursued genetic testing learn about that information. Now, this sometimes can be difficult. There can be families that have an estrangement, or sometimes people are adopted and it was a closed adoption. They have no information on their family. Our job as genetic counselors is to try and find a way that that individual feels comfortable to share that information with their family, but also respects their boundaries. And a lot of times, writing a family letter can help disseminate the genetic testing information. Sometimes going through a third party can also help disseminate that information. So we work with the family to share the information in a way that makes them feel comfortable. Genetic testing is confidential, and this information cannot be released to anyone without a signed medical records release form from the patient. Genetic testing information that we perform in the clinic is not shared with any databases. It's not used for research. It's primarily clinic testing. And so what that means is that the lab is only able to test for the specific genes that we ask them to test for. After 90 days, the sample is discarded. So I just want to make that very, very clear, because I know that there's a lot of concern about other testing that's done in the genetic space and the sharing of that information on databases and information that can be gathered from that. So that was a quick talk through genetic testing for inherited susceptibility to ovarian cancer. Our clinic has grown significantly since I first started, and I just would like to take the time to thank my coworkers, Lauren Hipp and Bailey Halswit. They're the other two genetic counselors that work in the clinic with me. And then our two attending physicians, Dr. Sophia Mariber, who is our medical director, and then Dr. Erin Cobain, who also is an attending physician in our clinic. And this is one of my favorite quotes, and that's my mom and my dad, who I unfortunately lost both of them to a cancer diagnosis. And I try very, very hard to think about them and try to think about how they would like to be taken care of as patients in this space. And so really, really try very hard to make sure that everybody is treated, fairly and with kindness, and because no one wants to feel like a number. And that's my favorite quote by Jim Valvano. So now I think we can take some questions, if that would be okay.
Absolutely. So I'm going to go ahead and end our recording here. So thank you all for that. Thank you, Kara, for that wonderful overview of genetic counseling and susceptibility. So I'm going to hit end, and then we'll open it up to questions for folks to ask.
So there were some questions that were sent in before the webinar. So